You know that universal ticking clock we all sort of unconsciously imagine during a medical emergency?
Yeah, absolutely.
Like for decades in the world of strokes, that ticking clock was just an absolute tyrant. I mean, it basically dictated every single decision in the emergency room.
It really did. It was a very rigid, very unforgiving countdown because, the moment a blood vessel in the brain gets blocked, roughly 2 million neurons die every single minute.
Yeah.
So the urgency is entirely justified.
Right. Every minute really counts. And today, we're tearing into a stack of medical research for this deep dive to uncover how doctors are, well, finally learning to beat that clock.
Yeah, the field is totally transformed.
It's wild. I want you to imagine for just a second that you or, someone you know is suddenly rushed to the ER with a stroke. The brain is quite literally starving for oxygen. What happens in those critical first few hours? We're going to look at the two distinct, extremely powerful tools that modern medicine uses to clear a blocked artery deep inside the human brain. A biochemical intervention and a strictly mechanical one.
And, the shift between those two tools, it really represents a massive revolution in how we think about the human brain. We are transitioning from relying solely on these rigid time windows to actually utilizing advanced tissue imaging and physically navigating inside the blood vessels.
It's like science fiction, but let's start with the foundation, right? Before we get to the physical clot retrieval, we have to understand the primary medical treatment that basically set the stage for everything. Thrombolysis, the chemical approach.
Right, the classic clot buster.
Exactly. When a patient is wheeled through those ER doors in the throes of an acute ischemic stroke, what is the very first line of defense? Like, I really want to focus on exactly what is given to them.
So the anchor of emergency stroke care is a drug called Hy-V alteplase. It's the classic clot buster, as you said, and it remains the only universally proven pharmacological intervention for an emergency acute ischemic stroke.
Okay, so I want to break down the exact dosing protocol here because the medical data outlines an incredibly precise formula, like down to the decimal.
It is very strictly regulated.
Right. So doctors give zero 0.9 milligrams per kilogram of the patient's body weight, capping out at a strict maximum of 90 milligrams. But they administer it in a very specific two-part sequence. 10% is given as an initial rapid, basically a quick push directly into the vein, and then the remaining 90% is infused on a slow drip over 60 minutes.
Yep, that's the exact standard.
Why that exact delivery method, though? Like, what is actually happening in the bloodstream when they do that?
Well, it really comes down to pharmacokinetics. You are trying to break down a physical barricade inside a blood vessel, right? So that initial 10% bolus, that's your battering ram.
Oh, I see.
Yeah, it floods the system, immediately spiking the concentration of the drug to initiate the breakdown of fibrin. And fibrin is, it's the tough, stringy protein that actually holds the blood clot together.
So the bolus basically punches the initial hole in the wall?
That's the goal. But a quick spike just isn't enough to dissolve a dense clot. The liver clears alteplase from the body very rapidly. I mean, if you just gave one big shot, it would vanish before the job was done.
Oh, wow. So it just flushes out too fast.
Exactly. So that subsequent 60-minute slow infusion, it maintains a steady, unrelenting assault on the fibrin structure until the clot ideally dissolves and, blood flow is restored.
I need to push back on this a little bit because pouring a chemical that violently destroys blood clots into a patient's brain sounds inherently dangerous. I mean, you are essentially turning off the body's natural ability to stop bleeding.
Right. That is exactly what you're doing.
So what does the risk-benefit math actually look like for an ER doctor making this call? Because this can't possibly be a magic bullet for everyone.
Oh, it's far from a magic bullet. And the math you're talking about, it's brutal. Let's look at the absolute optimal scenario. Treating a patient within the 0 to 3 hour window from when their symptoms first started.
The golden window.
Right. For every 100 patients treated with IV alteplase in that golden window, roughly 32 will see a clear functional benefit.
Okay, 32 out of 100.
But about 3 will be harmed by the treatment itself.
Wait, 32 benefit, 3 harmed. That is a really tight margin for a high-stakes intervention.
It gets even tighter.
Yeah.
If you stretch that time frame out to the 3 to 4.5 hour window, for every 100 patients treated there, roughly 16 benefit, and again, about 3 are harmed.
Wow. So the benefit just drops off a cliff.
Yeah, the risk of harm remains stable, but the chance of actual benefit drops by half simply because an extra 90 minutes passed.
Which brings us right back to the tyranny of the ticking clock. And when we use the word harmed, we need to be unflinchingly clear about what that actually entails. The primary danger highlighted across all this research is symptomatic intracranial hemorrhage, basically a brain bleed.
Yes, the incidence of that specific type of hemorrhage is around 6% in patients treated with alkaplase. Compare that to well under 1% for those who don't get the drug. And most of these bleeds occur within 36 hours of the infusion.
A 6% chance of causing a brain bleed while trying to fix a stroke. That completely changes how I view the doctor's decision-making process. I mean, it totally explains why there is such a rigid list of absolute contraindications.
Oh, the rules here are ironclad.
Let's dig into those deal breakers, because there are situations where you absolutely cannot give this drug right, no matter how severe the stroke is.
Absolutely. If there is active bleeding anywhere in the body or a recent significant hemorrhage or, say, major surgery, alteplase is completely off the table.
Well, that one's pretty intuitive. If you give a heavy clot buster to someone who just had their appendix out, they're going to bleed internally. But there are a few others that require some decoding. For example, blood pressure.
Right.
If a patient's blood pressure is sitting above 185/110, they are disqualified. Why does high blood pressure prevent you from giving a chemical clot buster?
Think about the physics of the blood vessel. The vessel is essentially a pipe, and the clot is a blockage. If the pressure behind that blockage is extraordinarily high, and you introduce a chemical that weakens the structure of the surrounding tissue while simultaneously thinning the blood,
The risk of the pipe bursting goes up.
it skyrockets. The pressure physically forces the newly thinned blood through the weakened vessel walls, and that triggers that devastating 6% hemorrhage risk we just discussed.
Yikes. Okay, another strict deal breaker involves patients taking anticoagulants, commonly known as blood thinners. The criteria states they cannot receive alteplase if they have an elevated INR. For anyone who doesn't work in a lab, what does an elevated INR actually tell a doctor?
So INR stands for International Normalized Ratio. It's essentially a standardized measurement of how long it takes your blood to form a clot. If a patient is on a daily blood thinner for, say, a heart condition, their INR is already elevated, meaning their blood is already artificially thin. If you add a massive dose of alteplase on top of an already elevated INR, you push the patient's blood into a state where it cannot coagulate at all.
So the bleeding risk becomes basically guaranteed.
Particularly anti, yes.
There is one more major contraindication that really caught my eye. Doctors will not give this drug if advanced imaging shows a large, already established infarct, meaning a large area of brain tissue has already died.
Right.
I would think that's when the patient needs help the most. Why withhold the drug then?
I know it feels cruel, but it is deeply rooted in the biology of the brain. When brain tissue dies, the blood vessels within that tissue also die. They become incredibly fragile and necrotic.
Oh, I see where this is going.
Yeah. If you dissolve the clot and suddenly allow high-pressure blood to go rushing back into a graveyard of fragile, dead blood vessels, those vessels will instantly rupture. It's called a reperfusion injury. So there's zero benefit, because the tissue is already gone. But the risk of turning a dead zone into a massive fatal hemorrhage is enormous.
So to summarize this entire chemical foundation, we have this highly calculated intervention. We know exactly what is given down to the milligram, but it is chained to a strict 4.5-hour window, comes with a severe bleeding risk, and is blocked by a long list of biological deal breakers.
Exactly.
So what happens when a massive artery in the brain is completely blocked by a dense, stubborn clot, and this chemical drain cleaner simply isn't strong enough?
That exact limitation is what drove the medical field to search desperately for an alternative. And it leads us directly to the mechanical revolution, mechanical thrombectomy.
Okay, here's the best way I've been able to visualize this shift, and tell me if I'm off base here. Giving IV alteplase is like pouring liquid drain cleaner down a clogged kitchen sink. You pour it in, you cross your fingers, and you wait, hoping the chemical reaction is potent enough to eat through the blockage.
That's a great analogy.
Right. But a mechanical thrombectomy that is like a plumber showing up, looking at the drain cleaner and saying, yeah, that's not going to cut it. They go in with a physical snake, grab the mass of grease and hair, and violently rip the clog out of the pipe.
The visual of the mechanical snake is highly, highly accurate. If you look at the descriptions of live angiograms performed during these procedures, it's just a breathtaking piece of engineering.
What does it actually look like on the screen?
Well, you start by looking at a monitor showing a completely dark, silent cerebral artery. The tissue beyond the blockage is dying. Then, the neurointerventionist makes a puncture in the femoral artery in the patient's groin and threads a microscopic catheter all the way up through the body, into the neck, and finally into the brain, pushing it directly through the clot.
Wait, from the groin all the way up into the brain? That sounds like science fiction. But how do they actually grab the clot without just, breaking it into a dozen smaller pieces that float deeper into the brain?
They use a device called the stent retriever. So once the catheter is past the blockage, they unsheath a tiny self-expanding wire mesh tube. This mesh springs open and physically embeds itself into the tough, fibrous structure of the clot. It tangles itself right into the mass.
Oh, wow.
And after letting it integrate for a few minutes, they slowly pull the entire apparatus backwards.
Dragging the clot out with it.
Yes. And on the angiogram screen, the moment that clot is removed, you see contrast dye flood into the previously dark vessel. It is an immediate, visible restoration of blood flow. I mean, it is fundamentally different from waiting for a biochemical drip to work over an hour.
While that sounds incredibly effective, the history here was not a smooth upward trajectory, right? I'm looking at a major trial from the past called IMS-3. It was a massive study testing this exact physical removal concept, and it genuinely failed. It showed no real benefit over just giving the chemical drugs. How's that even possible? Physically removing the blockage seems so clearly superior.
It really comes down to the gap between a brilliant concept and crude technology. The early devices used in trials like IMS-3 were essentially rigid micro corkscrews and suction tubes that were incredibly difficult to navigate through the tortuous, twisting blood vessels of the brain.
Oh, so they were just too clumpy.
Exactly. The procedures took far too long. By the time the doctors finally wrestled the vessel open, the brain tissue had already died. The clock beat them.
So they had the right idea, but the tools were like trying to perform watch repair with a pair of rusty pliers.
That is a perfect way to frame it. The tide didn't really turn until 2015.
2015 is highlighted everywhere in this research.
Because that was the year the Mr. Clean trial published its results, quickly followed by a whole cascade of other trials like Swift Prime, Extendia, Escape, and Reviscat.
All in the same year.
Yep. They all used the newer generation, highly flexible stent retrievers we just discussed. They could deploy quickly and retrieve the clot intact. The benefit for patients with large vessel occlusions was so dramatic that some of these trials were actually halted early because it was deemed unethical to withhold the mechanical treatment from the control groups.
Wow. Let's talk about how dramatic that benefit actually is. Because earlier, we looked at the number needed to treat for the chemical drug, where you had to treat roughly 3 people in the absolute best-case scenario to see one clear benefit. For modern mechanical thrombectomies, the number needed to treat for functional independence, meaning the patient can walk out of the hospital and live a relatively normal life, is between 3 and 7.5. That is astonishing.
It is one of the most powerful interventions we have in modern acute medicine, period. But just like the chemical approach, there are extremely strict eligibility criteria for exactly who can be wheeled into that operating room.
I want to challenge some of these criteria because they seem incredibly restrictive to me. A patient has to be 18 or older, they have to have been living independently before the stroke, and the blockage must be in a major pipeline like the internal carotid or proximal middle cerebral artery.
Correct.
But then there are these specific scores. They require an NIHSS score of 6 or more and an aspect score of 6 or more. Unpack these for me. Why would a doctor deny someone a life-saving surgery just because their clinical score hit a magic number?
Well, the NIHSS is a clinical severity scale. A score of 6 or more indicates significant disabling deficits like severe paralysis, facial droop, or loss of language. If a patient scores a 2 or a 3, their symptoms are relatively minor.
Okay, but it's still a stroke.
True, but navigating a catheter through the brain carries its own risk of causing a stroke or tearing a vessel. You do not subject a patient to the risks of brain surgery unless their symptoms are devastating enough to warrant that gamble.
Okay, so the NIHSS score proves the stroke is bad enough to justify the surgical risk. What about the aspect score then?
The aspect score is entirely different. It's an imaging score derived from a CT scan. It measures how much of the brain tissue in the affected territory is still salvageable.
Ah, okay.
A score of 10 means the tissue looks completely normal. A score of 0 means the entire territory is dead. So the criteria requires a score of 6 or more, meaning a significant portion of the brain has not yet suffered irreversible damage. If the score is too low, we run into the exact same reperfusion injury risk we discussed with the chemical drugs. Opening the vessel would just cause a fatal hemorrhage in the already dead tissue.
Got it. So you need a severe clinical deficit, but a brain that is still largely salvageable. And traditionally, doctors had to be able to achieve a groin puncture, literally starting the surgery within 6 hours of symptom onset.
Right, the 6-hour window.
Which brings us to the reality of the modern ER. Let's look at the patient case file we saw early in our notes. Someone arrives 90 minutes after their symptoms start. They have a confirmed large vessel occlusion, their blood pressure is safe, and their scores are perfect. Do doctors look at these two incredible tools and just pick one? Like, do they opt for the chemical drain cleaner or the mechanical snake?
In a modern stroke center, they don't choose. They deploy both simultaneously. It's called the bridging protocol.
So they basically throw absolutely everything at the wall.
You do. Assuming there are no contraindications, the patient is immediately given the IV chemical treatment. You push that 10% bolus, you start the 60-minute drip, and you let the biochemistry start chewing away at the fibrin.
Okay.
But you do not put the patient in a bed and wait to see if it works. While that chemical is dripping into their vein, the team is actively prepping them and wheeling them down the hall to the neuroangiography suite to mechanically rip the clot out.
You're dissolving the blockage chemically while physically driving a catheter up to grab whatever is left. That's incredible. And there are actually innovations changing exactly what is given during this crucial bridge phase, too. Let's talk about tenecteplase. I've seen it positioned as the successor to standard alteplase. What exactly is tenecteplase, and why is it supposedly superior?
So tenecteplase is a genetically engineered variant of the standard alteplase molecule. Scientists fundamentally altered its amino acid structure to achieve two specific goals. First, they gave it a longer half-life, meaning it survives in the bloodstream much longer before the liver breaks it down.
Which means?
Which means you can actually give it as a single rapid bolus, just a single shot, without needing that cumbersome 60-minute continuous drip.
Oh, that alone seems like a huge advantage when you're trying to quickly move a patient down a hallway into a surgical suite. No IV poles to tangle with.
Exactly. It's a massive logistical advantage. But the second modification is even more important, and that's enhanced fibrin specificity.
Break down fibrin specificity for me. What does that actually look like at a molecular level?
Well, standard alteplase activates plasminogen, which is the enzyme that breaks down clots somewhat indiscriminately throughout the entire bloodstream. It thins out all of the blood, which is what causes that systemic bleeding risk we talked about.
Right, the 6% hemorrhage risk.
Exactly. Tenecteplase, on the other hand, is genetically modified to largely ignore free-floating proteins. It has a high affinity specifically for the fibrin strands that are actively holding the stroke clot together.
So it acts less like a chemical carpet bomb and more like a heat-seeking missile targeting the specific blockage.
That is the exact clinical goal.
Ah.
And because it binds more tightly to the actual clot structure, studies demonstrated it achieves higher reperfusion rates than standard alteplase when used as a bridge before a mechanical thrombectomy. It's successfully opening vessels more often, which is why advanced stroke centers are rapidly adopting it.
We have these incredibly refined, genetically engineered drugs and highly advanced stent retrievers. But I keep coming back to the elephant in the room here. Time. 4.5 hours for the chemical infusion. 6 hours for the mechanical retrieval. What happens to the patient who goes to sleep feeling fine, wakes up paralyzed, and has absolutely no idea when the stroke started? Or, someone who lives in a rural area and simply cannot get to an advanced hospital within 6 hours, are they entirely out of luck?
This is where the most profound paradigm shift of the last decade has taken place. For years, the medical community made a fundamental error. They treated those 4.5-hour and 6-hour windows as absolute, unbendable biological laws for every single human being.
They treated the ticking clock on the wall as the only metric that mattered.
They did, but two monumental clinical trials, Dawn and Diffuse 3, completely dismantled that rigid thinking. They proved that in very carefully selected patients, the eligibility window for mechanical thrombectomy could be safely extended from 6 hours all the way up to 24 hours after symptoms started.
Wait, 24 hours? How is it biologically possible for brain tissue to survive a blocked artery for an entire day?
It's possible because we moved away from generic time-based rules and embraced highly individualized tissue-based rules. We do this by using advanced perfusion imaging.
Okay. What does that show?
Instead of just taking a standard CT scan to look at the anatomy, doctors inject a contrast dye and use sophisticated software to track exactly how fast and in what volume blood is flowing through the microvessels of the brain.
So they are painting a real-time functional map of the brain's cellular health. What exactly are they looking for on that map to justify doing a surgery 20 hours late?
They're looking for a very specific pattern called a perfusion mismatch. The software identifies two distinct zones. The first is the infarct core. That's the dark area of brain tissue where blood flow has dropped so low that the cells are definitively dead. Nothing can save the core.
Okay, that is the permanent damage. What is the second zone?
Surrounding that core is a much larger territory called the penumbra. This is brain tissue that is really struggling. The blood supply is drastically reduced, and this starvation is causing the patient severe clinical symptoms, the paralysis, the loss of speech. But the cells in the penumbra are not dead yet.
They're still hanging on.
Exactly. They are basically hibernating, kept on life support by collateral blood vessels, these tiny side streets that are working overtime to deliver just enough oxygen to stave off cell death.
So the penumbra is like a neighborhood suffering a massive brownout, just waiting for the main power grid to come back online.
That is the perfect analogy. If the perfusion imaging proves a patient has a small core of dead tissue, but a massive penumbra of salvageable tissue, that is a favorable mismatch. It proves that this specific patient's unique biology and collateral blood flow have successfully kept that tissue alive for 16 or even 20 hours.
So the advanced software, not the rigid clock on the wall, dictates who can still be saved. That completely rewrites the rules of emergency medicine. I mean, you are quite literally letting the patient's own cellular resilience make the final call.
It's the ultimate expression of precision medicine. We finally stopped treating every single patient as if their brain died on the exact same generic timeline.
If we step back and recap this entire incredible evolution of stroke care, it is just staggering to think about how far we've come. We started in an era where we relied solely on chemical clot busters. We measured out exact 0.9 milligram dosages, tied our hands to uncompromising stopwatches, and basically accepted a terrifying 6% risk of brain bleeding.
Yeah, those are tough times.
And today, we deploy aggressive combined protocols. We give highly engineered fibrin-specific drugs like tenecteplase, while simultaneously rushing the patient into surgery to physically drag the clot out with a mechanical wire mesh. And we guide every single one of those decisions using real-time tissue imaging that shows us exactly which parts of the brain are still fighting to survive.
It really highlights the relentless, iterative refinement of medical science. We evolve from a state of relative helplessness past a certain hour to actively rescuing patients up to an entire day later.
Which brings me to a final thought I want to explore with you. We talked extensively about how the early mechanical thrombectomy trials like IMS-3 genuinely failed. The medical community had the idea of physically removing the clot, they tested it, and it didn't work. The approach was deemed a failure.
Right. And, the medical community could have easily walked away right then. They could have published the negative results, declared physical clot retrieval a dead end, and accepted that chemical treatments were the only option.
But they didn't. They realized the underlying concept wasn't flawed. The physical tools just hadn't caught up to the ambition yet. They needed the flexible stent retrievers and the advanced perfusion imaging that finally arrived in 2015. So considering how mechanical thrombectomy is now considered one of the most decisively effective interventions in the history of acute medicine, what does that say about the rest of the scientific landscape?
It leaves you with a deeply provocative question. I mean, how many other brilliant ideas or potential medical breakthroughs are currently sitting in the failed pile of science? How many discarded interventions are actually fundamentally sound concepts, simply waiting for the next generation of technology to catch up and finally prove them right?
Maybe the cure isn't impossible. Maybe the tools just haven't been invented yet. We started this deep dive talking about a loud, universal ticking clock. For decades, that clock was an absolute tyrant. But what we've learned today is that sometimes you don't actually need to beat the clock. You just need to invent a better way to look inside the bomb. Thank you for joining us on this deep dive. You are now armed with the critical high-stakes insights into how modern medicine fights back against a stroke. We'll catch you next time.